Thank you for joining us this morning. Again, my name is Mariela Lopez. I am the Regional Asthma Coordinator for US EPA Region 9. This is a California Asthma Financing Work Group informational webinar. It will be about social impact bonds and pay-for-success models. We will be hearing from Brenda Yamashita from Alameda County and also Kevin Hamilton from Fresno AIM. I wanted to start by mentioning that Tracy Enger, our representative from the Office of Air and Radiation Indoor Environments Division, will not be able to join us today. She had a family emergency. However, I will provide the information that she was going to provide to us. So I'm going to start with that. So essentially, this is our path to sustainable financing from the EPA perspective, and that's EPA-wide. And essentially what Ms. Enger wanted to disseminate to you all is that it's remarkable that we are at a place where we're able to discuss options for sustainable financing for in-home asthma care services. And it's been a long road to get here, and she wanted to share EPA's story with you and underscore the importance of the work happening in California on this front. And since 1998, EPA has invested in increasing awareness and action around the importance of managing indoor environmental triggers to help control and manage asthma. And as awareness and acceptance has spread, and healthcare and housing programs have begun translating environmental evidence and care guidelines into practice, we have now been able to shift our focus to system-based changes that will spread the sustainability of comprehensive asthma care, both inside and outside the clinic setting, which I know that you are all aware of. And we've known how to manage asthma effectively for 20 years with quality healthcare, medicine, and environmental controls, yet still today, as you all know, kids with asthma are frequently ending up in the ER or hospital because they and their caregivers aren't able to properly manage the disease. And I'm sure you all appreciate uncontrolled asthma severely limits the quality of life for children and families and is the leading cause of student absenteeism from this chronic disease and poses a huge economic burden to society. Poor asthma control is associated with high healthcare spending, including emergency room and hospital utilization. The traditional healthcare system is not equipped to address environmental causes and exacerbators of disease, such as asthma, because the healthcare required to bring asthma under control very often needs to be delivered at the home and in the community as much as it does in the clinic. Addressing the environmental causes of disease requires reaching people where they live, work, and play. And in the case of asthma, it requires addressing specific factors in an individual's environment, work that we know we can do more effectively and at a better cost outside the clinic setting. And as you all are probably all aware as well, asthma is very individual. So really looking at the home, environment would be a very important thing for asthma management. Home visits provide that one-on-one time that families need to figure out an approach that they can follow to help keep their child's asthma under control. And we believe that this is particularly important when addressing asthma disparities. For almost 10 years now, EPA has been helping communities nationwide to develop and deliver in-home asthma care that includes environmental controls, typically delivered by non-clinical staff. We are now trained on systems-based changes that will support expansion and sustainability of care outside the clinic setting. Tracy also wanted to mention that we're not alone in this. The federal family recognizes the importance of leveraging systems at all levels, national, regional, and local, and across sectors to effectively address asthma disparities and ensure that all children have access to comprehensive asthma care, both in and outside the clinical setting. The Coordinated Federal Action Plan to Reduce Racial and Ethnic Asthma Disparities that was released May 31st of 2012. If you haven't read it, I suggest you do. It's a great document. Serves as a platform for cross-agency collaboration aimed at eliminating disparities and expanding access to comprehensive care, including in-home interventions. The Disparities Plan also acknowledges the role of the community in supporting delivery of in-home asthma care services and the need to create sustainable financing sources. The plan also provides a nice framework for action and draws on agencies' areas of expertise to leverage environmental, healthcare, and housing systems. So as you can see, it's HUD, HHS, including CDC, and then also the EPA. This graphic highlights key assets that our federal partners are able to bring to the effort to expand access and secure sustainable financing for in-home asthma care services. I'm not going to run through the specifics, but I would like to highlight the role of the asthma summits in this process, and also the slides will be available to you after so you can go through the specific little bullets that are assigned to each agency. And if I can just remind you all to mute your lines, and if you have a question, to please put it in the chat box. And we'll be answering questions as they come up in the queue at certain intervals. And if we are not able to answer them, we are going to create a question and answer document that will be available after the webinar. So just to move on towards the summits. So the summits, similar to the one held in LA in September 2015. So that was Region 9's first summit. Are key to advancing local conversations and growing a network of multidisciplinary stakeholders committed to scaling up and securing sustainable financing for in-home services at the state level. Since 2012, more than 15 states have been represented at 11 regional summits held in partnership with HUD and CDC. And if you look at the little map that I'm about to show you, all the stars show where there have been asthma summits. And so for sustainable financing options for in-home asthma care, one of the key topics discussed by communities invested in identifying sustainable financing is the concept of braided funding. And this concept underscores the importance of bringing multiple streams of funding together to cover the full spectrum of in-home asthma care services, from education to environmental assessments and interventions. In many cases, this type of approach requires institutional changes and leveraging of systems and partnerships to integrate work into portfolios. So just to mention again, so at our January 12th California Asthma Financing Group, we talked a lot about programs needing to have some evolution to kind of fit this type of braided funding. So I think this is an important slide, and again, they'll be available afterwards so you can take a look at this graphic. And the illustration depicts two primary funding streams and what they typically will and won't pay for. Under health, they cover traditional healthcare funders like public and private insurers, as well as state and local health departments. So when you look at populations that are disproportionately impacted by asthma, this often includes poor and minority children. State Medicaid is often a primary payer for these populations. But what specific program components and types of providers will Medicaid reimburse or cover? There are examples of Medicaid paying for education, assessment, and light remediation provided by licensed and non-licensed practitioners. And when it comes to structural changes, this typically falls out of Medicaid's purview. Provider delivering in-home asthma services is a critical component. And just one particular story that I can tell you is that in Atlanta, the state of Atlanta Public Health is having an insurance provider help pay for the state to do these in-home asthma interventions and healthy homes kind of assessments and interventions. So it's something that is happening out there, and definitely contact me if you want more information about that. And in terms of housing, there may be a need to look for housing funding streams to cover structural interventions. And so under the emerging potential funding sources, that's also a key to developing a robust financing portfolio and can help fill in some of the gaps or incentivize participation. Social impact bonds and Pay for Success programs are key opportunities in this area and is what this webinar will be all about. And just to give you some very long definitions of both of these models, so a social impact bond, and I know you guys can read this yourself, but basically it's a contract with the public sector in which a commitment is made to pay for an improved social outcome. So I'm going to give you the short one for that one. And Pay for Success is an approach to contracting that ties payment for service delivery to the achievement of measurable outcomes. So again, very similar, but in Pay for Success, it's most likely the government that will pay, and in social impact bonds, it's it's some kind of private organization. So I'm going to turn it over to our, I will say, experts in this arena. And we're going to turn it to Brenda Yamashita, who is the Program Director of the Asthma Program for the Alameda County Public Health Department, and she has served with the department for many years and serves on many boards and committees as it relates to children and asthma. So I'm going to turn it over to you, Brenda.
Thank you. So I'm going to talk about the Pay for Success portion today, and I'm going to start by giving you a history because we didn't just wake up one day and say, we'd like to do Pay for Success. You have to put a little effort in before you can do that, and you also have to prove those outcomes so that somebody is interested in working with you. So we started back in 2001, and that's probably when asthma was starting to get a highlight. There's always kind of diseases come up at different times, and asthma was really being highlighted at that point. So we had the third highest rate in the state, and our health officer looked at that and said, you know, we need to do something about this as a county. We're at the third highest rate. And at that same time, First Five and Every Child Counts was offering funding around asthma. And they actually designed our program. So we ended up using social workers for our in-home case management because that's what they requested. And as you know, often you have to follow a funder's request if you're expecting to get the funding. So we did do that. We started out small. We started with 0 to 5-year-olds in one city in our county, and that was in Oakland. So our original design was an in-home visiting program where we addressed asthma education. So we looked at what is asthma, what happens when you're having an asthma attack. We'd look at, could they find their medications? Did it take them the 2-whole-hour visit for them to find those medications? And then had they expired? Or were they in a paper bag with the other 5 kids' medications, and was it difficult to try and separate them out? So we'd be looking at all of those kinds of things. We also, because we use social workers, we're addressing psychosocial issues. We were looking at housing, employment, food, because as everyone knows, if you have a chronic disease and you can't address those issues, it's hard for someone to focus on their disease and improve their health. We would connect them to services such as dental appointments, housing, getting the 0 to 5-year-olds into preschool, making sure they had their immunizations, they were up to date with them. We would look at things within the house to try and identify triggers. So leaks, animals, 25 pigeons living in their roof, mold, pests, and we would connect them to services to get those things remediated because it was important in being able to get the asthma under control as well. And so we'd also work with property owners to try and get those changes made. And we would do forms for the American Disabilities Act where we'd ask to have carpet removed. And they're not required to have to pay for it, but they should give us permission because it is a protected disease. So we would often get permission, and sometimes the property owner themselves would pay for it and make the change, and other times it had to be on the person living in the property. We always ensured they had a medical home and that they had medical insurance. And then at the same time, we were collecting data. So we were looking at ER visits prior to us doing case management, and then post, hospitalizations. We would do pre and post tests with them to show increase in knowledge. And we'd also be looking for symptom control, and we would measure all of that and track it. So in about 2005, we grew up. We went into serving 0 to 18-year-olds. We also expanded to all 14 cities that are in our county. We updated our database. We improved our educational materials. We did reviews on all of this. And at this time, we were serving around 250 to 300 clients per year. And I had 3 social workers that were doing that. And our funding came from voted on tax that we received. We had some money from Kaiser, Master Tobacco Settlement, Alameda Alliance for Health, which is our Medi-Cal managed care, and Targeted Case Management, which is a federal program administered by the state where, as a public health department, we can bill for managing high-risk clients, and asthma children fall into that. So that's where we kind of ended, probably in about 2015, which is when we decided, you know, we need to look at something else. What else can we consider? And that's when we said, okay, let's consider pay-for-success design. And in order to do that, we needed to increase our staff. So we went up to 5 social workers. 3 of them were handling the targeted population that we were going to be measuring the pace for success under. And 2 of them were taking care of all the rest of the patients that didn't fall into the criteria that we had set for that group. We had to expand partnerships. There were a lot of people we had to add, and I'll talk about them in a few minutes. And we did set that criteria. So the criteria was they had to have been in the ER, for some reason this is backwards. They had to have been in the ER or the hospital in the last 12 months for asthma. They had to be an Alameda Alliance for Health client, and that's because the actuarial data or the actual data we would get on their cost savings or their hospitalizations or their ER visits or how they've changed in trends of what they've been doing in their medical life, that's where that documented information was going to come from. So we needed them as a partner. They had to be 0 to 18 and then living in our county. Our target is to hit 250. We are in the midst of our program right now. So our 250 are supposed to be met by the end of this coming June. And as a part of that, we also partnered with UC Berkeley, and we looked at all of our educational materials, all of our intake forms. We wanted to look at reading levels, make sure we had the right number of languages, that we developed some of our own. So there was we needed nutrition. We developed that. A lot of the things we also used were Alameda Alliance for Health. And because we were partnering, that worked out well. So some of their educational materials are in the binder we give to the parents, and some of ours are. And then we added some things that UC Berkeley thought were important that they felt maybe we had left out. That was the next line down, which is the asthma control test and some information on spare the air. On our intake forms, we asked some additional questions. We added some things like height and weight of the child, which we hadn't asked about before, but UC wanted to look at, is obesity playing a part? We asked about their meds when we first met them and their meds when we left, because sometimes that changes, and we felt it would be good to know. We also looked at the parents' education and employment, because UC felt that that could have an impact, and so they wanted to be able to measure that. So those were things that we added to our form. And we had to make sure that everybody receives the same service, because this is a study. We're looking at what is the best way to approach this, what we're doing, does it work, and if it works, it saves money, and if it saves money, is that pay-for-success partner willing to then share some of that with us to help support the program. So everyone is seen by us, where we're doing the medical and psychosocial, and everybody is seen by our Healthy Homes group, which is doing the home inspections, what we call an asthma treatment, which is where we bring in a janitorial service to clean the soft surfaces, the hard surfaces, and to put boric acid underneath the appliances. And they get a spec meter in their home. And this is something we weren't doing, so this is some technology we added to try and, again, prove that what we're doing is working. And the spec meter measures the particulate matter in the home. And this has really been fascinating for the parents because they kind of get hooked to it and they want to go and see, when's it going up? What am I doing when it goes up? So it's good for teaching them a lot of interesting lessons. They find that when they cook, it goes up. So we found that to be a great tool. So as far as our partners, you can't do a pay for success by yourself. It just won't work. So Healthy Homes was one of our partners. We decided that since we had really good medical psychosocial skills, and we had some housing skills too, but they had really good housing skills, that we should partner. And so we partnered for them to do the home inspections and the asthma treatments. And then Alameda Alliance for Health, we have been working with them since 2001. And again, that's our managed Medi-Cal. And they're one of our largest referral sources outside of Children's Hospital. They also help fund for our visits. And they're the ones who are going to collect the data. So they are our pay for success partner. They are the ones who, if we can show some success and cost savings, that will consider sharing additional savings with us. Impact for Health, which I realized I did incorrectly, that 4 should be a number, for guidance and coordination, because we had never done this before. And so they were there to help us sort out what we needed, partner with who we needed to be with. UC Berkeley, because they're the ones who helped us improve our data collection, look at how we had written things up. Were we going to be able to collect the data we really wanted with the way we were asking questions? And they will be the ones to do the analysis in the end. And then an actuarial who will review Alameda Alliances for Health cost analysis and billing information to find out what was the change. So they'll look at the child 12 months before we intervened and 12 months after to see, was there a change in spending around their medical costs as related to asthma. And then Third Sector Capital was the one who gave us some advice on design and how to attract investors. None of us do this on a regular basis, so that's why all these partners are important. These components are necessary to try and prove this model, to try and work with other partners that you might not have worked on on a regular basis and may not know the best approach. So they all help us out with that. So that's always been very helpful, all of our partners. Excuse me. So some of the things to know, and these are things we've learned as we've been going along. Pay for success studies cost. And, you know, we sort of knew it, but we really didn't know how much and who was going to need to be paid and so on. So it costs about $1.5 million for us to get this going. And about 5 of that was for partners, because UC Berkeley costs, the actuarial costs, every partner who worked with us has some cost associated to it. And then we had to go, and then we had everybody paid for, and we had all this money set aside, and it was like, okay, but now who's paying for the program, for the clients to actually be seen, and for ourselves and Healthy Homes to be able to run the business. So we ended up, through a lot of foundations and so on, being able to fund the partners, and then the funds to see clients, we ended up having to go to our Board of Supervisors and say, we need to borrow some money to pull this off. We want to prove this. We want to work on this. And they agreed with us and gave us that funding. We were very fortunate. And the partners are very vital to the complete picture. The pay for success, you have to have somebody who's going to agree to do that. So Alameda Alliance for Health is that person. But you have to have identified that person ahead of time. You have to get an agreement with them. There's lots of pre-work to do, of building relationships and designing MOUs and et cetera. And so that, they have been a great partner. All of our partners have been great partners, but there's time, effort, and money that needs to go into it, especially maintaining it, trying to coordinate. So Healthy Homes is an entity within the county that's not a part of public health. and my program is a part of public health, and we had to take 2 employees from 2 different groups, bring them together, and get them to work together, which it had its ups and downs because they had not been a team previously. And we had to get them to work and act as a team and to trust each other and to say they can go in and do the housing and you don't have to worry about it. They can go in and do the medical and you don't have to worry about it because you're doing the housing. So there was a lot of communication and work around that. And the team, the staff needs time for that transition. It wasn't the fastest sell I've ever done where you just go in and say, hey, we're going to do this. You had to take some time to work with them, to listen to them, and so on. And you have to realize that not every family you go to is going to say, I'm on board with this. I want to participate in this, because it required them to see both of us. So they got 3 visits from us. They got 3 visits from Healthy Homes, not all on the same day. We did them on different days, but they had to commit to participating around that. And some people said, I don't have time, and some people said, I don't want to do it. And as we all know, some people fall off the radar no matter what. So you always have to account for more than what you want to hit. And it takes time to get the outcome measures. We need 6 to 12 months after discharge to be able to start to look at noticeable changes. So everybody has to remember that even if you do a 12-month program, you're going to need time after that because you're going to have to be able to measure what took place, and you have to be able to look at data, and there needs to be a 6-month process for that to happen so you can go back and see actually what took place after. Did I really reduce those ER visits and hospitalizations? And so you need to account for that length of time. And, we kind of went back and forth about what that length of time should be, and I'm still not sure we're totally there. As I said, we don't end until June, and so there's still a lot of things we're going to find out about. Some of the things we have found out about, Berkeley wanted us to add a spare the air days and explain to people the concept. Well, we're starting to find that concept is not well known within non-English speaking groups. And so one of the things we're thinking and we're actually researching right now is that maybe Spanish radio, Spanish TV, or any other Asian TV, whatever other languages there might be out there, may not be announcing spare the air days. And that may be why they're not known. So we're working to try and find out if they are doing that, and if they're not, can we get them to start working with the Air Quality Board and actually have that start to happen. Our pre and post test, I've always kind of said, geez, I want like 90% of the people to get 80% or better at the end of the test. Well, what we found out is that our test, which is a new test, and so we're going to have to analyze its effectiveness, this last time around, I had 5 people who didn't get 80% or better, and so that was bothering me. So I went back to look, and of those 5, 4 of them had Spanish as a first language, and the 5th had Arabic as a first language. So it could be a language issue. But when I looked at their pre-test and post-test, they may have gotten a 3 right on their pre-test, but they got right 8 on their post-test. So that made me happy because there was a significant change. And so I have to start to think about how I measure that and what I'm really looking at. We're still on self-report for the reduction of emergency room visits and hospitalizations, only because we haven't finished far enough for the actuarial to step in and get the actuals out of Alameda Alliance for Health. So we are showing a reduction according to the parents, which is what we've always measured for years, but now we're trying to get something that's more validated. So we're going with the actual information from the insurer. The asthma home treatments that we're doing, the parents and the families very, very much appreciate them. And sometimes when you do something that somebody appreciates, they put more of an effort into keeping it up and taking care of it themselves. It also takes, so we'll go into homes that are like in great shape. They probably don't need our cleaning, but we do it anyway because everybody gets the same services. And then we walk into homes where they're drowning because they can't keep up with the house. So we said, okay, we're doing this baseline maintenance for you, and they're then really trying to keep it that way. And so it's taking them out of that hole they were in, trying to get their house back into order. It's got it into order, and now maybe it'll be easier for them to keep it that way. We're having success with property owners. Property owners often think that we have a lot of pull, which we don't, but we let them think we do. We don't say we do, but we just let them think it. And so we've done things like gotten insulation and all the sheetrocking changed in one apartment because there had been a big leak and there was mold. We've had heaters that weren't functioning at all be repaired. And just a lot of different things that make the living environment much better. So we are, like I said, we're still at the process of finding out what all of our outcomes are going to be. So maybe sometime I can share that later after we've gotten past that point. But we're seeing a lot of positive things right now, and we're very excited, and we're excited about the new things that will happen because this has been a learning process for us as well, and it still is. But we're looking forward to all those new and exciting learning opportunities. Thank you.
Thank you. Thank you so much, Brenda. I have a few specific questions that appear to be for you, so I want to take them now and have you answer them, and then we'll move on to Kevin. So the first question is, where is the role of certified asthma educators in your new program, if there is any?
We haven't done that yet. We've talked about it. I've talked about the social workers going ahead and doing the testing. We have not gotten to it yet because this is taking up quite a bit of time. But it's a great process. I promote it. I think people should do it. And I know we will in the near future.
Perfect. And just so everybody knows, there's only 3,500 certified asthma educators in the United States. So we need you guys. And then also, UC Berkeley is a large university. So can you explain which department you're working with?
It's the public health department. We're working with Len Syme and Linda Newhouser.
Great. Thank you so much. And then one more question was that how long did the program last for each family? I think you mentioned 12 months, but...
Not with our intervention. It's usually, if everything went perfectly, it would be 3 months because they'd get 3 visits from each of us. But depending, so we've had kids who haven't been in school for 2 years, and that took us a year's worth of time to get them back in. And so sometimes we have issues that take us a little longer to resolve. The target is around 3 to 6 months.
Okay, thank you. And then another question was, asthma home treatment sounds a lot like medication delivery, or is it looking at environmental triggers? And I would err on the side of environmental triggers, but I will ask you to answer this question.
It is, and we were calling it environmental treatments, and some people were misunderstanding what that meant, so that's when we changed it to asthma treatments, but you're correct.
Okay, great. Thank you. And one more, the last question is, how much money as a percent of the amount invested do you think the Pay for Success will save the funders? And this is just, obviously, you're not done yet, so, you know, just...
No, but I do have a little bit of a reference. So back in 2012, we had Alliance look at, I think it was over 200 and some kids, but there was like 256 that were 0 to 5, which is the high users usually. And they looked at 12 months prior to our intervention and 12 months after our intervention, just off the top of their head. And we have reduced costs for up to 50%.
Wow.
We're hoping that the same shows up this time, but we haven't done that look again since 2012, so it's definitely time to do that.
Absolutely. Okay, well, thank you so much, Brenda. There'll probably be questions for you during the question and answer session. So with that, I am going to introduce our next speaker, which is Kevin Hamilton of Fresno AIM. And just to give you a little background on Kevin, Kevin is he's the Chief Executive Officer of the Central California Asthma Coalition, and he is focused on reducing the burden of chronic respiratory disease and environmental health impacts Central Valley-wide. He has served as a developer coordinator, administrator, and director for multiple programs in both hospital and community-based settings, serving poor and underserved communities in the San Joaquin Valley. Kevin serves on numerous boards and committees associated with grassroots community capacity building and local, state, and regional policy development. So with that, I will turn it over to you, Kevin, and thank you so much for participating.
Thank you, and good morning, everyone. I'm going to move through this fairly quickly, our program is the Asthma Impact Management Program for Fresno. This is a program that we started in 2013 and looked at testing the social impact bond model against the standard asthma in-home intervention. I think Brenda has described that pretty well. In the second slide, you'll see our long and winding road that we took, and I think Brenda has described that very well already, and I won't dwell on it. Next slide, you'll see that asthma is a crisis for our children and communities here in the San Joaquin Valley. A number of surveys have been done now by both the California Department of Public Health and our local departments of public health and our local UCSF medical program, amongst others, looking at, in partnership with CCAC as well, looking at asthma prevalence in our schools, and the average is around 1 in 5. The highest in the state is actually Kings County. That just about edges out everybody else with a 24.6% average in their classroom, which is about a little over 1 in 4. So these are kids that still have the diagnosis. They are not the group that was at some time in their lives diagnosed with asthma. So I think it's important to clarify which group of asthmatics we're talking about. Many of the stats we see are lifetime diagnosis stats. And so moving on to the next slide, you see that there is strong evidence over time, and I think we all know this, so I'm not going to dwell on it, for asthma in-home management. I started the first program as a partnership with the Relational Culture Institute back in 1991 here in the San Joaquin, working with farm workers in Mendota and the town of San Joaquin, small farm worker towns. And we've been sort of working away at this ever since, trying to find money, pretty much soft money, wherever we can get it, with occasional backing from hospital corporations along the way, who see sort of an alignment here every time asthma visits in the ER start to roll up to significant costs. The programmatic results are pretty straightforward. As you can see, we set up in this case an actual case managed approach to this, looking at a recruitment base of about 800 patients to start with. We use the same kinds of criteria that were used in Oakland, looking at an ER visit or a hospitalization or 2 or more unintended primary care visits in the previous year. We distilled that really large group down to about 83 potential patients, and by the end of the study, of the 83 people that we recruited, it was diluted all the way down to 37 who were able to complete an entire year in the program. If we had added 7 more in, that made it to 9 months, and we're actually reevaluating this data now to take a look at them. It would have been a few more. We've continued to recruit. That study ended, the analysis phase took a whole year. That ended last September, and we'll talk about that in just a minute. We were really looking at how much money we were saving, as you had mentioned in the past. We're looking at the per member per month values. Our partners in this were UC Santa Barbara's actuarial department, Ian Duncan over there, and HealthNet through our Tri-County Health Plan, Calviva Health. They're the contractor there, and they provided the original patient group that we recruited from, pulling out the asthma patients they felt had the most risk. And it really becomes a risk issue for health insurance plans. Interestingly enough, they have formulas that they put in place that allow them to evaluate what is the risk that this patient will end up in the emergency room, what is the risk they'll end up in a hospital. I am not supporting those or contradicting them. I'm just accepting that in doing this kind of work, if we're going to have relationships with these kinds of businesses, we have to understand their business model and include it in our calculations. So what we did find is people tended to self-select who was willing to participate as we were recruiting patients. And as we moved down through the group, we found that the patients that were left over who didn't participate, who we put in the control group, ended up being patients with lower risk scores. As you can see from the column on the right, it says mean risk score. We use tools to evaluate, like the asthma control test, to evaluate the progress of these patients across time. As you can see from this graph, this group of patients improved across that period with higher and more improved ACTs as the program went on through the end of the program. I will say that the majority of the patients in the program were primarily Spanish-speaking. We used 2 community health workers. Those community health workers have been trained by EPA in the EPA Home Environmental Evaluation Program, and one of them is an AEC. And so, yeah, exactly. She's so excited about that, actually, and so am I. So we were happy to see these results in that group. I think a lot of this is a result of the people doing the work coming from the communities that they're working in. I support that model and use it whenever possible. So next thing we looked at is what's called a mini PACWELL, a mini pediatric quality of life survey. It's 13 questions that have been developed to evaluate the physical, emotional, and social problems for children with asthma. And it's a NIH-validated test. This is much more difficult for our families, and getting a Spanish translation certified was an exercise in and of itself for us, but we were successful in getting that signed off on. And as you can see across the period of time, symptoms, activity limitation, emotional function, general feelings about wellness improved for this group of people. So we were feeling pretty good about that. It's something that we repeated initially and then at quarterly intervals across the year post-initial visit. We also saw a reduction in visits overall, not quite as high as we had hoped for. Self-reported was radically, and I'll show you that in a moment, self-reported was different than what the actuarial reports were. So patients self-reported a decrease of 70% in hospitalizations. We actually had a decrease of about 30% according to the claims record. The ED usage decreased by 81%, again in self-reported, and the claims record showed about 70%. Outpatient visits did match actually fairly well with the self-report. So it just continues to demonstrate the weakness of self-report data and the challenges also that are involved in us getting it. It took literally a year, I'm not exaggerating that, to go through all the hoops that we needed to go through to get this data for the final report. Just incredible. So moving on to slide 11. You can see our costs associated with the intervention. The total service delivery costs reflect the cost of the actual grant. The service delivery costs per case at the bottom reflect the actual cost. So we were funded with a lot of money to do this. We ended up not spending as much money per patient as we expected to. Tied up a lot of money in home remediation and not nearly as much in staff. And as we were able to keep the cost contained within a single organization, and that allowed us to, I think, be a little more efficient in how we spent our money. So we determined that the total cost for an average of 3 home visits per patient, some had as many as 6, some as few as 1, and the phone call follow-up time, which we calculated the time people spent on the phone, the time they spent doing records, everything that we could put into the time study was put in there. Drive times for people, times that they spent in office, again, working on those records. Just general scheduling, calls time, everything we folded in, and we ended up with a cost of about $842 a patient. It's important to know how much it costs you to do something so that you can determine how much money you need to do it. So, and whether it's scalable or not, I think is an important thing to do. So moving on to the cost-benefit analysis from the actuarial folks at UC Santa Barbara, I think we came up with a very realistic number of about $3.63 returned on every dollar invested. So total program cost in the office here was $113,056. and or the savings, excuse me, and the cost was $31,175 to do that work. So people can argue about this. I'm sure they will. It depends on how intricate and how many people are involved and how much they're paid. I will say that my folks at my organization, we have a salary floor of $15 an hour. So that's probably less than folks, I know it is because I worked in a county, less than a county maybe, but or some hospitals at higher levels, but it's certainly well above minimum wage, and here in the San Joaquin Valley is considered a good wage. So again, when we looked at the actuarial results, you can see them here. We calculated in not just the ED visits, the inpatient visits, and inpatient costs, admits and costs. We also looked at the cost of drugs, which is important because, as you can see, the cost of drugs actually rose, and that's because patients are more compliant with their medication. So again, part of the social impact bond concept is we're reducing costs of the healthcare system, requires that we have a detailed inventory of those costs. That has to include the costs that occur during wellness that is related to the intervention. Moving on to what we've actually learned. So this is the stuff that was most interesting to me. Having worked in this home intervention world for 20 years now, I wasn't surprised about the efficacy of the intervention. I'm a true believer. I know that this intervention changes people's lives and improves them dramatically. And I think it's worth every dollar that we spend on it. But the partnering throughout this has been the most challenging, developing these relationships. So you've got essentially the federal government as a major partner. I think Marielle or Marisol mentioned this, that 56% of the burden will lie on the federal government, and this is mainly through the Medi-Cal share of costs. So in California, the feds, other than for the adult ACA expansion group, pays 56 cents. The state contributes 44 cents. So you've got to deal with both the state and government and the regulations regarding their ability to move public money to a private entity to pay for a service or to reimburse, say, an investor that's investing in a social impact bond to make them whole and return savings back to them from the system. Then underneath that, in California, again, we've got this sort of unique system amongst the states where we have turfed out essentially our responsibility to health plans through managed care for the Medi-Cal population. This has created an additional layer and quite honestly makes the state not necessarily as excited about programs like this because they don't bear the direct responsibility. They're not facing a lot of that risk. They've transferred that off to these health plans, and they have to deal with it. So in other states where this is moving forward more aggressively, you'll find the state still operates the Medicaid program, and so they're facing those losses directly, and they're more interested in the cost savings associated with these kinds of interventions. And then a new IPA association relationship the health plans have developed to manage their claims, people like LaSalle and EHR, Pinnacle Claims Management, there's a whole list of these out there, create yet another layer within this whole healthcare financing system that, again, is taking money off the top, out of the administrative fees, and through bonuses along the way for saving money by essentially decreasing the amount of visits that patients have, or paying providers less, and all kinds of interesting strategies there. And at the bottom of this, you've got healthcare providers who in Medi-Cal are not feeling real strong about having any money carved out of their existing really poor payment system to pay for anything else. While they support it, they also want more reimbursement for themselves, and they deserve that as well. And so that creates a very challenging situation for us in the state to develop a pay-for-performance system. Moving on to, again, what we've learned about these health plans is that generating buy-in from them, you have to have that right from the beginning. We really underestimated this, quite honestly. We figured about 6 months to develop health plan relationships at the beginning of this program. It took us a year and a half. So you run smack into the contracting and quality assurance departments in these health plans, And let me tell you, this is not their priority. So we did eventually get success, but it took a lot longer. This project we estimated would be 3 years, ended up being almost 5. So having that flexibility, I want to credit the California Endowment who funded this through Social Finance and Collective Health, our two investment partners. And I really appreciate them being flexible with us and while not providing any extra money, allowing us to string and no-cost extensions out much further than they would normally do in a standard grant period. So we did learn, and we were using a community health center group of patients that, in fact, the community health center is doing pretty well at controlling asthma. Out of the 908 patients, as I mentioned, we only had 20% who actually met the selection criteria. And we went back a year and a half looking at their utilization and visits during that period. And that we really worked at the idea of reaching these patients, and it was just as challenging as we expected it to be. This is the most difficult group to reach. We did everything from cold visits, cold call, drive-by visits to multiple time calls across the day and mailings, and we were fairly successful, but it really required flexibility on our part. And here in the Valley, the geography really works against us. As you move out into Fresno County, you get 50, 60, 70 miles away from Fresno for a lot of these communities where the patients we were dealing with. So as we move along, ideas to scale this up, we think direct investment from governments and other entities like Department of Healthcare Services and Medi-Cal health plans are really important. The pay for success contracts with back-end players are still needed. We need a good one to test this with DHCS. We've worked with them, with RAMP and the Children's Movement and others, had conversations with them. This is going to be a big lift, and I think we've got a long way to go on this particular aspect. They see this Medicaid reimbursement, this payer class under AB 391 that's before the state right now, and see reimbursement for community health workers, but people will, I think, be surprised and shocked by how low that reimbursement rate will be. If you work in the system, as I have for so many years, you know what that rate's going to be, and of course they won't fund any of the remediation activities, so we're still going to be leaning heavily on soft money.
Hey, Kevin, sorry to interrupt
yes.
you. I'm just going to ask folks, if you can stay past 12 o'clock Pacific Daylight Time, please do so. Kevin still has a few more slides to go through, and if you'd like to hear more about what he's doing, I would ask you to stay on, and we're going to continue till he's finished, and then have a little bit of question and answer. So if you can, please.
I think we only have 3 more slides here, Ben.
Okay,
so
Kevin, go forth.
Okay, so we have several things on the boards right now. As I mentioned, the state plan amendment, AB 391. If you're in California or you're not, please send a letter to your whoever leads your legislation or your state senate or assembly member, or send a letter to the health committee at the assembly, which is going to hear this on April 4th. So this is a big deal. I think everybody should take a look at this bill. Again, I'll say it, AB 391, and make sure you understand what's in it and send a letter. We've got a lot of organizations pushing this. Again, the California Public Health Association, CFAN, and others. Healthy Homes is behind this, and continue to have discussions with the medical health plans. HealthNet and I have been going back and forth for about 14 months now, working on an agreement that would actually get us both where we need to be. So don't underestimate the amount of time it takes to work with health plans that don't necessarily have the same goals or drivers that we do. I don't know if people notice, but most health plans put asthma back on their hit list for high-risk diseases this last year. It was off the list for the first 2 years of the ACA as they got hammered with new adults with complications related to diabetes and congestive heart failure. So they're starting to get those under control, and asthma's come back up again now. So again, we're starting to see these programs across the country, and I think that was mentioned on an earlier slide. And we want to know if we can translate this into opportunities for California. We think that we need at least $1 million in a Social Innovation Fund grant to explore this in 5 sites across the country, and that's what Social Finance is developing right now. There's over 2 sites, so we're continuing to move on that. And
please remember to mute your lines. Thank you.
I'm sorry. So I think I'm just going to go ahead and move to the last slide 39 here. They're not sequential. There weren't 39 slides in this. I'm sorry. But South Carolina has a really interesting nurse-family partnership that I think is worth exploring for those of you who are interested in this kind of thing. It's also working on a waive your program, and it actually puts these nurses working with the Medicaid payer there, Healthy Connections Medicaid, that's South Carolina Medicaid program, and first-time low-income mothers, along with their Poverty Action Lab. And they're focusing on kids that are at risk for asthma, so I think that's really an interesting program. And I thank you very much. Sorry for the rush there at the end. And it's 12 o'clock on the nose.
It is 12 o'clock on the nose. So thank you so much, Kevin. And we did have a question. Do you have plans to publish this data, and if so, where?
Yes, so we are in the second cohort now. These 2 people are carrying 152 patients at this point, and we are working, we've decided to work with the Health Policy Institute here in Fresno. The endowment has expressed an interest to us actually continuing this work and like I say, examining the first cohort in year 2 and year 3. So what hasn't been done yet that we've seen is a second-year evaluation on the same group of patients, or even a third year. So we need to understand better the synchronicity of asthma as a disease, which tends to be episodic and cyclic across time. So we need to be able to prove, I think, once and for all, that the cost savings here are not only in year 1, but also reach out into year 2 and year 3, and in fact get better. We also understand very well that it takes longer for really sick asthma patients to get better, even with this intervention, than for those who maybe only had an ER visit. So as we discovered, our patients that had had hospitalizations, in some cases multiple hospitalizations, we really didn't start to see that improvement until about month 6. And they were the ones that required as many as 4, 5, even 6 home visits. And a lot of case management, community health workers attending physician visits with them and helping them model good communication skills with their primary care providers, making sure that they understand what's happening to them in this very strange culture they're living in 2,000 miles from their homes. So I think that's just lessons learned there.
Thank you, Kevin. I think there's one more question being typed in, but just right now, while we are waiting for that question, for more information about AB 391, there's a link that Joel provided about the assembly bill that Kevin mentioned. And it was actually not a question. It was just a thank you to you, Kevin. So thank you so much again. If there is no more questions, I am going to, if there's no more questions for Brenda or Kevin, I'm going to close the webinar. But essentially, I just wanted to invite you all to join our California Asthma Financing Work Group if you are able, and you can contact me if you would like to do that. And please join us for our next working call on April 26th at 11 a.m.
Great, thank you.
Thank you, everybody. Have a great day.